It gives me great pleasure to introduce Professor Jenny Myers to start off this next session. Jenny's someone I've known for a long period of time when she was just a very, very young researcher and developed into, as you can see from her bio, into a very busy, very high profile research worker and clinician. And she is internationally and nationally renowned in the areas of preeclampsia and particularly in biomarkers. So she's going to talk to us about the prevalence of severe biomarker needle outcomes in angiogenic biomarker diagnosis and preeclampsia, a 5-year experience from a UK tertiary hospital. I think this is a very important area. We tend to often think of preeclampsia as the end point of studies, but in fact, preeclampsia is just the beginning of the road as far as the women are concerned, and the long-term outcome is also important. So Jenny, please enlighten us.
Thank you very much, Jimmy. Can you see my slides and hear me okay?
I can hear you fine, yes, and see.
Yeah. Okay, well, thank you very much for the kind introduction, Jimmy. I'm going to just race through some data that's been collected by a group of predominantly of medical students who've worked with us and our team over the last few years. And Nat Berry, who's our specialist hypertension midwife, who leads our MAVIS, which is our Manchester Antenatal Vascular Service. It's the team of clinicians, midwives and doctors who look after women affected by preeclampsia. And it's where we've been able to, the infrastructure really kind of that has enabled us to do a lot of work in the space of implementing and investigating the impact really of introducing angiogenic biomarkers into our routine clinical practice. Okay, so I think everybody on the call will be familiar about the journey of placental growth factor testing. There were a couple of large-scale blinded diagnostic accuracy studies which demonstrated the high degree of diagnostic accuracy for both PLGF as an isolated test and also the soluble FLIT PLGF ratio as an indicator and a way of an adjunct to making the diagnosis of preeclampsia. And we, a few years ago, while we were on this journey between the Pelican and Parrot studies, published an implementation study in our hospital in Manchester looking at outcomes related to women who'd been managed with the knowledge of angiogenic biomarkers. We then went on to do the Parrot study, led by Lucy Chappell and the team, that showed that routine use of PLGF-based testing improved maternal outcomes and was cost effective. And as people know, that led to the NICE guidelines being changed and the NICE diagnostic accuracy guidelines being changed so that we would all trusts, certainly in England, were funded to offer PLGF-based testing. And thanks to Marcus and the APEC team, PLGF-based testing is now being implemented in many other corners of the UK as well. Recently, we've just published another clinical outcome paper, which again just looked at our experience of implementing biomarkers, and there were about 660 women included in that paper, looking at the association between the biomarkers and some of the other characteristics of maternal disease. But today I'm just going to think a little bit about using angiogenic biomarkers potentially in the context of identifying cohorts of women that we might identify towards new treatments and the introduction of clinical trials for new treatments for preeclampsia. And I think we all know, those of us that work clinically or in research related to preeclampsia, that it's a very heterogeneous condition. It can be quite difficult to define. It's very difficult to diagnose in any woman who's got pre-existing hypertensive or renal disease. And so we're almost at a kind of reset point, I think, in terms of being the opportunity to look at the natural history of this condition in the context of women who've been identified and diagnosed with this perhaps more cohesive label of abnormal angiogenic biomarkers, which delineates them as a group with with a definite change in their placental function, and that change in their placental function driving the features of the clinical disease. The other thing that's really important for the introduction of new clinical trials for preeclampsia is thinking about the expected frequency of adverse events, both for mums and babies. It's really held us back in obstetrics, the fear of causing harm, and clearly that's got to be at the forefront of any clinical trial that we do. And it's really important that we frame new interventions in the context of the frequency of complications which affect this group of women. So I think people will be familiar with the siRNA soluble FLT therapy, which is currently in development. Well, it's now been developed and it's ready for first in pregnancy trials. This is one of the studies, but this is the study that showed the effectiveness of giving this siRNA against soluble FLT to reduce soluble FLT production by the placenta. Was done in a baboon study, and there have been several other preclinical models which have demonstrated that by reducing soluble FLT expression by the placenta, perhaps we may be able to ameliorate some of the consequences of preeclampsia and prolong gestation at those really critical early preterm preeclampsia gestations. This therapy, which is being developed by a company called Comanche, have now completed their first in human study, which was in non-pregnant individuals, which was a safety toxicity study, which went very well. And they've now got regulatory approval to do the first in pregnancy study in Australia, and the UK application will be going in very soon. And it's likely that we would be for this phase 2/3 study that we will be doing dose finding, and we will be doing dose finding, and the absolute kind of priority of this first study will be to monitor safety. And be able to monitor safety, it's really important that we've got some benchmarking and some natural history in terms of poor outcomes in which to compare. So the data set that I'm going to share with you today has been collected over a 5-year period at St Mary's Hospital in Manchester. We're based in the centre of Manchester City, but we're also now 3 hospitals that sit in the north part, the central part, and the south part of the city. It's a very diverse population with obviously high areas of social deprivation. And we've got PLGF-based testing. We use the soluble FLT PLGF test in Manchester because we happen to have a Roche biochemistry analyzer. So that's what we've been currently using in our clinical practice. And when we merged with the 2 other hospitals across the city in 22, you can see, well, you might not be able to see on that graph, but the numbers of tests that we do per month has gone up. And so we're now got tests from a large cohort of women across those 3 hospital sites, which covers about 16,000 births per year. I suspect for those of you who work clinically, you've all got management algorithms that look similar to this in terms of the diagnostic thresholds that we use associated with soluble FLT PLGF-based testing. And we use 85 to diagnose preeclampsia, and we manage those women as preeclampsia on very careful either inpatient or outpatient surveillance programs. And in our hospital, if women have got a PLGF ratio between 38 and 85, we know that about 30 to 50% of those women will ultimately develop a clinical diagnosis of preeclampsia. Many of them end up getting delivered before they get to that diagnosis, but they're a very high risk group, and with unfortunately a very high prevalence of adverse outcomes as well. And we monitor those women very carefully until they develop their clinical label of preeclampsia. And so the aim of this study is really just to describe pretty simply the maternal and neonatal outcomes in women who had a soluble FLT PLGF ratio above 38. And for the purposes of this, we've only included singleton pregnancies, and we've collated detailed maternal and neonatal outcomes, and these have all been collated from the routine healthcare records. So I think the first interesting observation not really that surprising, is that nearly half of the abnormal tests that we did, or abnormal tests that we found, were after 35 weeks pregnant. And that reflects the fact that we know that this condition gets, the prevalence of this condition increases dramatically towards the latter few weeks of pregnancy. So in terms of a therapy that would be aiming to prolong pregnancy and prolong gestation, the first really important observation is that about half of the women that we diagnose with abnormal angiogenic biomarkers wouldn't actually probably be eligible for a trial, because we really haven't got much time, and it would be safe, given the findings of the Phoenix trial, we should already be talking to those women about the risks and benefits of actively progressing with birth once you get over a gestation of 35 weeks. These are the sort of high-level maternal outcomes from this cohort. It's not quite 1,000 women, I'm embarrassed to say. It's 997. But this is 997 pregnancies. You can see that on the median number of days from having an abnormal biomarker test to baby being born was 9 days. But you can see a very wide range there. So although the interquartile range is 4 to 18 days, you can see that some women are delivered the same day, with some pregnancies lasting as long as 100 days. So a very, very heterogeneous group in terms of presentations, even though they've all been diagnosed with abnormal angiogenic biomarkers. About a fifth were delivered before 34 weeks. One of the sort of hidden benefits of angiogenic biomarker diagnosed preeclampsia is the timing of steroids, and we've seen a steady increase in good timing of steroids based on making that certain diagnosis, and people thinking very carefully about the need and the timing for steroids and getting those as close to birth as possible. And certainly in our practice, that has improved year on year. Not surprisingly, a high number of operative births, and about 7% of these women develop a serious maternal outcome, which is very significant maternal morbidity in this group of women. About 20% of women needed high dependency care, and 2% of women had a placental abruption. And I think that's one of the really difficult challenges about managing women with preeclampsia expectantly, is the risk of an abruption, which is the thing that puts them and their baby at highest immediate risk. In terms of neonatal outcomes, these are really, really important for the context of clinical trials. And these are some of the figures that we need to have in our locker, ready to compare when we're looking at data monitoring and data safety in the context of interventions. So high numbers of growth restricted babies, as we would expect, and unfortunately quite a high perinatal loss rate as well, as unfortunately we would expect in a cohort of women with early onset preeclampsia. About just under half of the babies in this entire cohort went to NICU, and about 20% of babies over 35 weeks went to NICU. High rates of babies needing respiratory support. And then these outcomes at the bottom, things like interventricular hemorrhage and necrotizing enterocolitis are complications which we obviously really, really worry about in our preterm infants. And again, really important that we understand how prevalent those conditions are when we're monitoring safety outcomes in a cohort of women who perhaps have taken part in an intervention study with this same defined disease. The other thing, which I'm embarrassed to say I don't think any of us have really paid enough attention to as well, is the kind of high rates of congenital anomalies in the babies born to women who were affected by preeclampsia. And some of those congenital anomalies may have an interaction with the disease etiology as well. But again, really important that we have got these as evidence of kind of where the pathology sits in terms of these women affected by this condition. So just as we'd all like to be able to predict the outcome of football games, what we'd really like to be able to do is understand, when we're faced with the woman with a new diagnosis of preeclampsia, we'd really like to understand whether she's at risk of developing severe complications, and how long is her pregnancy likely to last, and can we use angiogenic biomarkers better to understand which women are going to develop serious outcomes? Well, not really, I'm afraid to say. So we know that all of the blood tests that we do at the point that women are diagnosed with preeclampsia have poor prediction for the women who are going to develop severe adverse outcomes. If the blood tests are already beginning to be abnormal at the point that the woman is first diagnosed with preeclampsia, if she's already got a raised creatinine, if she's already got a raised ALT, if she's already got low platelets, then clearly she is very likely to develop a serious adverse outcome. But if her blood tests are all in the normalish range, that is not predictive of serious adverse outcomes. And angiogenic biomarkers in this cohort of women who've all got abnormal angiogenic biomarkers, again, don't really strongly pick out the people who are going to develop serious adverse outcomes. And the reason for that is not because the angiogenic biomarkers don't correlate to disease severity. The reason is that these biomarkers are done at a completely random point in the woman's disease etiology. So we test these biomarkers at the first opportunity that the woman presents with a suspicion of the disease, and that might be quite early on in her preeclampsia journey. And because her biomarker was abnormal, we've not repeated it because we know that there isn't any value in repeating abnormal biomarkers for clinical management. So the poor prediction here is not related to correlation between biomarkers and disease. It's to do with the fact that we're measuring them at very random intervals in a woman's disease journey. What I would really, really like to be able to do is to try and identify the women at highest risk of an abruption. And I'm very disappointed to tell you that none of the biomarkers seem to really identify which women are at high risk of abruption. And we haven't yet found anything. We've only got 21 women in this data set, but we haven't found anything in that group of women that does delineate who's more likely to have an abruption or not. I think very important, these are really serious outcomes for mums and babies, and 13 of the 21 abruptions in this data set happened after 34 weeks. And so I think, again, a sage reminder that we need to be thinking carefully and having good conversations with women about timing of birth once we get to those more advanced gestations, 34, 35, 36 weeks, certainly. So just in the last couple of minutes then, let me just quickly show you some data on women who might be eligible for a clinical trial. So in terms of the women who we want to keep in a clinical trial who are likely to stay pregnant for more than 3 days after their test, do the biomarkers help us there? Well, you can see on this kind of slightly arbitrary dichotomization of women who are still pregnant 3 days after they had their biomarker test, you can see there is a very strongly statistical significant difference. But if you wanted to use the biomarkers to predict who's going to still be pregnant in 3 days' time, the AUC is still very poor. So we're still in this tricky thing that we've got biomarkers that do give us some indication of severity of disease, but they're not very good at predicting how long a woman is going to remain pregnant. And then again, just looking at the subset of women who we might include in this first trial for Comanche of the soluble FLT therapy. If we were to include women who were over 26 weeks, so not including those very, very precarious early onset pregnancies in this first safety trial, and looking at babies over 500 grams and over the first centile, that's only actually about 157 women in this cohort. So 157 of those initial 997 women who had abnormal biomarkers, only that 16% would actually be eligible for a clinical trial if they were the entry criteria. And that's really important for our planning and thinking about how a trial like that might progress. And I've just compared again arbitrarily the women who stayed pregnant for more than 3 days and those that were delivered in that first 72 hours. And again, statistically significant differences in the biomarkers, but not with significant predictive accuracy. Women who were going to get delivered, about 70% of them already had abnormal blood tests, which is not surprising. And the rates of severe adverse outcome were higher, again, indicating that those women were much later in their preeclampsia journey than the women who stayed pregnant for longer. But you can see again, even in the women who were pregnant for longer, very severe perinatal morbidity and mortality in that group. I'm just going to skip past that, again, just shows the similar data in the same way, but in the interest of time. So this is real world data. This is not the same as doing blinded studies and looking at correlation with disease severity. This is very much women being managed in the context of their abnormal biomarkers, and we really need to make sure we remember that in interpreting the data. It's single centre data, although it's across 3 different hospital sites with quite a broad geographical range across the city, but still nonetheless a single hospital trust. I think it's really important that we all remember that the rate of abruptions is not as low as we would like it to be in women who are affected by preeclampsia. And the numbers I presented here today are going to be very helpful, I think, in terms of planning intervention trials in that group of women where there's an opportunity perhaps to prolong pregnancy. So thank you very much for your attention. We've got time for 1 or 2 questions, I'm not sure.
Yeah, we have that. Andy, you're wanting to ask the question.
Yeah, Jenny, sorry, I'm going to barge in here because I've been thinking along the same lines as you for some time now. I guess, when you use AUCs on severe conditions that have very, very low prevalence, because they have incredibly high false positive rates, they always look bad. So I'm not sure they're a great way to kind of evaluate the potential use in clinical pathways. But if you've got a very high sensitivity, which you do for these incredibly bad outcomes, it does really help in a clinical pathway in terms of saying this baby isn't going to die and this baby's going to be fine and you don't need to worry about it. So maybe we just for the people who don't spend years of their lives thinking about predictive statistics, we shouldn't throw the baby out with the bathwater, as so to speak.
And I'm not suggesting for a minute that these are all women with abnormal biomarkers with a diagnosis being managed in the context of that diagnosis. But I think it's good to just appreciate what the biomarkers tell you, which is that you need to be really worried about this woman because she's got disease that's going to get worse. But it's about, obviously at the very early gestations, which women are likely to benefit from prolonging pregnancy.
Well, almost more importantly, the ones with the normal ones you don't have to worry about. This
data I've just presented today is just all the abnormal. So I wasn't thinking in terms of the diagnostic accuracy between normal and abnormal. This is just the natural history of women with abnormal biomarkers. But in the wider context, into absolutely right. And actually the AUCs, when you compare normal with abnormal, are very, very good, actually, aren't they?